Welcome to our TMIT Research Test Bed monthly webinars. I'm Dr. Charles Denham, and I'll be your host today. We are absolutely thrilled to have a terrific group today, and we want to remind everyone that they can go to safetyleaders.org to get the slides. It's just a wonderful topic today, the 5 rights of end of life, which we know is a critical area of interest today. And so what I'll do is I'll be going through the slides. And what I'd like to do is just remind everyone to go to safetyleaders.org. And in the upper right quadrant of the landing page, you'll see Dr. Tim Jessick's image, and you can register there. And in future, you will also be able to take advantage of the slides and other resources that we will provide there. Our disclosure statement is on the next slide, and that is on slide number 4. And we have no disclosures of financial relationships that pertain to this topic. You will see that the 5 rights of end of life care has a trademark on it, and we've learned that that just allows us to protect the content that we are giving away. On the next slide, you'll see our social media addresses, and over 2021, we'll be much more active in social media than we have been. I'd just like to draw your attention to our purpose. Our purpose is we will measure our success by how we protect and enrich the lives of families, patients, and caregivers. And this end of life topic is very, very pertinent to that premise. Our mission is to save lives, save money, and create value in the communities we serve. And we try to live our core values, which are spelled by I-CARE: integrity, compassion, accountability, reliability, and entrepreneurship. And we seek to live those values. Just for those of you that have joined us for the first time, our network evolved over a number of years. We established TMIT Global originally in Texas 37 years ago. And over that 37-year period, our network has grown to 3,100 hospitals and 3,000 communities, and a subject matter expert pool of those that give their time to help us that are clinicians, caregivers, nurses, doctors, pharmacists, many in administration, many in support, in consultative support of healthcare, and board member and governance leaders. Before we start, we always want to have the voice of the patient to set our compass heading on the patient, their families. And Dan Ford has been a tireless contributor to patient safety. He has served in many roles. He's a retired healthcare search consultant. However, he's been a published author in patient safety. He served on many committees and donated his time in many different ways to local healthcare organizations. Probably most importantly, he and members of a Saturday morning team that continues to meet and has met for over a decade helped get the hospital-acquired conditions across the goal line and was verified by CMS, which has saved hundreds of thousands of lives and tens of billions of dollars. And although Dan has contributed to many projects, that is, I think, one noteworthy project. He's a retired healthcare search consultant, a veteran of the Vietnam War, naval aviator. Dan, would you please start us off with your comments, and then we'll move on to our wonderful speaker, Dr. Tim Jessick. And we're not hearing Dan.
Dan, press 6 on your phone to unmute.
Go ahead, Dan. We're not hearing Dan right now.
How about
there we go.
Are you on, am I on now?
Yes, go ahead, Dan. Please go ahead.
Okay, I'm sorry for this technicality. I'd like to welcome everybody. Everybody that's on the call, our faculty, and as I'm guessing, I'm assuming that this subject is very, very personal to most everybody on the call today, especially given the last year, the pandemic plus whatever else is going on in our personal lives. We've got a wonderful speaker, Dr. Tim Jessick. He has great experience, very appropriate experience. He has a great heart. His values are perfect for this, and he has a wonderful passion for what he is doing. I think this will be an opportunity for the next 90 minutes to take away some really good points. Thank you, Chuck.
Thank you, Dan, and thank you for your steadfast commitment to patient safety and quality. We have a wonderful panel today, and because this is such a pertinent topic, we have Arlene Salamandra, who is also part of the Saturday morning team, and Dan and this entire team won the Pete Conrad Global Patient Safety Award. Jennifer Dingman, who is also, as is Arlene, a tireless contributor with Dan to patient safety, and Jennifer has been leading our patient and family voice for our coronavirus care community of practice. And we'll have Heather Foster, an RN and nurse preventionist, infection preventionist, who will also react to what we're hearing today. And so what I'm going to start with is in the first 10 to 15 minutes, just cover our coronavirus community of practice, because this is such a critical issue. This is the image from Johns Hopkins' wonderful dashboard on the crisis. Before the last surge, we saw the run up to the surge on the slide that you see before you that shows the deaths that we encountered right into December. And then we ended up and we've only just recently dropped in terms of 2 infections every second in America and 2 deaths every minute. We know we have global participants, and so the number is much higher around the world. But here in the United States, just for the majority of our audience, we've only just breached that curve. Our biggest area of importance now, though, are the variants, and the variants are doubling in a matter of days, which will lead us to a bigger problem. I pulled the curves from the IHME modeling group, who have done a terrific job in continuing to model what's going on in America today. And the slide is from this morning. We see that the deaths are now dropping in America. However, we see in April and then through May that we see another surge. So we have to brace ourselves for another surge. And we've pretty reliably reflected the worst case of what's going on. Now, infections are even greater, and you can see that the infections may be as high as they were in December from these new variants and from the relaxation of the isolation and the public health requirements. So it's really, really important. Now, as Dr. Jessick and I, who worked yesterday preparing the slides, discussed, we always want to have the most timely information we possibly can. And this just came out today in the New England Journal of Medicine, an excellent article on vaccines. I highly recommend it. It gives a historical context. And although we want to move to Dr. Jessick immediately, I just want to put a pin in this article for you and highly recommend what we can learn from the history there. So when the March crisis hit in New York City, we assembled then a 60-member team, and the folks that are on this call are part of that team. And you'll see, in addition, a number of interviews that we had through our Discovery Channel documentaries, and a number of these experts participated as a rapid response team to focus on the essential critical infrastructure workers. In August of 2020, educators at all levels, K through 12, and higher education, as well as those that support education, all were also declared part of this group of essential critical workers. So we started our community of practice, of which this webinar is a community of practice for patient safety, to convene, connect, celebrate, and co-create in order to have impact and change. And we are working with scout groups, faith-based organizations, first responders, and many organizations. Now, this program grew out of a program we started 5 years ago. And the 5 years ago, we started what's called MedTech. It's the merger of the medical best practices and the tactical best practices for emergencies. Those of us in medicine and those of us in first responder disciplines of law enforcement and military, it's the combination of those two to target these 8 leading causes of death you see on the right side of the page. Unfortunately, infections became the leading cause of death. However, there are a number of articles that are on our website that can give you can review, in addition to some that relate to COVID that are in Campus Safety Magazine. We ultimately have 8 articles there. This program that we started here where I live in Orange County, we started in schools after we learned about the 8 leading causes of death at Texas Medical Center, where we worked with Dr. Greg Boats and Dr. Chief Adcox. And fortunately, we were able to save the first life before our first class were graduated in Orange County. And now we're training people that are 8 to 80. So what did we learn? Well, our hypothesis in March was that the family unit is the Achilles heel, that family transmission is the Achilles heel. So our goal was to then focus on these transmission chains, because the majority of infections we felt were going to come from the community and go through our essential workers. Now, we didn't have data to support it. However, now many studies now support that that is the problem. So were we lucky? Was it, I believe, I'm a person of faith. I think it was, more of a divine sort of inspiration than anything, but we didn't know. And it turned out that we were right. And our belief was that if we save the families, we save the worker. If we save the worker, we can save communities across the nation. So we're very blessed now to be leading the world's largest study in this area of family transmission chains. And what we did was we generated, because adult learners and the youth all learn different ways. Some want to watch a 4-minute video, some want to watch a 90-minute course, some want to read a medical article, some want to read other articles in the press. We developed a program to meet all those needs. And so that's actually what we developed. We established a Survive and Thrive program roadmap. And as you see on this slide, we started out with coming home safely, then keeping our kids safe, creating your safety plan templates. Heather Foster, who will speak a little bit later, and Dr. Boats and multiple contributors in emergency medicine helped us put checklists together for providing care at home. We put a plan together for what to do through 2021. Our last webinar, and it's the first week of every month. And thank you, Jennifer Dingman, for being such a wonderful spokesperson at the beginning of each one. We focused on the emergency rescue skills, the loop of getting your loved one to emergency care and back. Our March webinar will be focused on the vaccines, the variants, and victory, and we'll also cover what to do with the ICU. So in the next 3 or 4 minutes, I'll just cover these before Tim Jessick speaks. But we covered the hot zone, the warm zone, and the safe zone of your home. We covered the background risk areas, and now we see new guidelines from the CDC that fit beautifully with the course that we developed, and we'll be continuing to add to that, of being able to make these decisions regarding our kids based on the local infection risk, not just a one shoe fits all, which is, I know, frustrating to so many, but it's a nuanced decision. We put together a plan for Survive and Thrive, of a safety plan of readiness, response, rescue, recovery, and resilience, and what those best practices were. I won't cover them in detail. Go back to the slides and look at them. We came up with templates that you could use for your family, which were, and this is the rescue template, a picture of a college student. And our program is really not only focused on families of those that are blood relatives, but also your family at college. It may be your roommates or your housemates in your household, and we put that together. We put together a number of checklists, and you could go back and see them. If those of you are now having to care for someone at home, please go back to that program. It's a series of very detailed checklists on how to take care of someone. And then we addressed testing and vaccines and how we proceed through that. Our last webinar was on emergency skills. And Tim, many thanks for helping reconfigure your work to the 5 rights framework. This is a slide of the 5 rights of emergency care, which we delivered as an entire webinar with Dr. Toff Peabody. And our last webinar, we had Dr. Casey Clements from Mayo Clinic and Dr. John Fox from here in Orange County from the University of California, Irvine, address the critical issue of getting your loved one to and from the emergency department safely. And then finally, we put together a program over the holidays because people were getting together, even though the CDC said not to put together a strategy. If you had to get together for the holidays, here's a checklist to prepare to get together during the event and after the event. And now we're heading towards spring break. So our youth and young leaders of our program have asked us to tee this up with you again and say, here's a checklist during spring break when you bring families together on ski trips and that kind of thing. And the next two programs are vaccines, variants, and victory, as well as what to do. They're in the ICU. So that takes us to a survey. Kyle, would you please put up our survey? We're going to ask all of you to participate in the survey that only takes a few minutes. This helps us drive this content regarding COVID, but also patient safety. And we ask that you all submit it. It's totally anonymous. We won't know who you are to be able to participate with it, but we very much appreciate you participating with this survey. Let us know if you've also already been surveyed. We'd still like to hear from you because we know that things have changed. The first question is about readiness. Are you and your family ready to care for a loved one? The second question is response. Does your family know what to do? And a family is a living unit. It could be nobody related to you, but the people that you share a household with. Are you ready to respond if someone gets infected? Rescue. Do you know what to do if they develop severe symptoms? And then recovery. Do you have a plan to help recover your loved one or your family through the recovery period, which is so critical? And then finally, we use the term in law enforcement and anti-terrorism of resilience. Target hardening. Is your family prepared and to learn and to make itself less at risk? So I'm just about 1 minute over. Tim, I'm so pleased to introduce Tim Jessick, who is a terrific leader. We brought him back because of great demand. He spoke to us at the end of last year and did such a wonderful job doing so. And so Tim is the post-acute medical director at Theta Care, a new position for him. He's board certified in palliative care and family medicine. He's co-founder of the president of the Palliative Care Network of Wisconsin and a member of the Academy of Hospice and Palliative Medicine and American Academy of Family Physicians. He's a terrific speaker. We loved listening to him. And as Dan said, you can just feel Tim's heart for this. I think what was really exciting, Tim, in your last presentation was what a great patient safety program one can have to address, or an organization can have for great end of life care. Not only is it a good return on investment, it's really a great program to put together. And I think it really delivers patient-centered and family-centered care. So those things said, I am really, really pleased to have Tim now be our spokesperson and speak on behalf of this. And I am going to now release the system to allow him to share. Can you go ahead and share, Tim?
Not yet. It's not letting me yet.
All right. Let's see what we can do here to.
Try it again, Dr. Jessick.
I'm not sharing, so Dan, there you go. Very good.
Thank you very much. And thank you all so much for joining today. It's such a pleasure to be with you all and to be with this group. As Dr. Denham mentioned, I presented a couple months ago on great end of life care and how it can really drive patient safety. And I promise I won't go through the same presentation because a lot of you saw it already. And I promise it won't be all death and dying and sad stuff, right? But my hope and my focus a couple of months ago is really presenting the case more of the business case, more system case of how important great end of life care can be. What I'd really like today is change focus just a little bit. And the focus is really more on clinicians and what clinicians can do. So docs, nurses, APCs, social workers, and the like, but also patients and families. We don't talk as much with and about patients and families. So what would that look like from their perspective? So I do want to focus a little bit more on those areas today. Before we get there, though, a couple critical questions, and sorry to make you think so hard right off the bat, but this really sets the tone, I think, for what we want to discuss over the next 45 minutes or so. And really the first critical question, I want you all to think about this on your own, is why is an end-of-life program important? Why does that matter? Because when we talk about an end-of-life program, we're not talking about hospice necessarily. We're not talking about the last hours to days of someone's life. But why is something like this really important? Well, one big reason is that in order to provide really good end-of-life care, you really need to teach a skill, and you need to develop a skill. Communication really is important, and it is something that you have to learn over time. If you ask my wife, I need to keep learning because I'm not quite there yet. But even after a palliative medicine fellowship, I'm still learning how to talk to folks and to meet them where they are. So really developing that skill is really crucial. But the other piece is more of a culture aspect. We are very clinician-centered in medicine right now, and we're very siloed in medicine right now. So how do we change that culture so we can really become more person-focused, not just patient-focused, but person-focused? And how can we also become more family-focused as well? So we'll talk a little bit more about that over the next few minutes. So here's another good one. Is an life program good business? Well, we can't talk about business, right? We're talking about end-of-life care. We're talking about caring and feeling and things like that. Well, as a nun who was a CEO of a health institution told me once, no margin, no mission, right? So you really do need to present the business case to folks. We do need to look at how really good care can enhance that business case for folks. So part of what you're going to hear me say a couple different times is that a good end-of-life program really can improve quality. If we can provide care for someone that they want and make sense for them and is consistent with their goals, that's good high quality care. And we can do this in a way that all of a sudden we decrease cost. If we're not doing things to folks that they don't want, that's going to help with costs. We're not going to be doing procedures. We're not going to have folks in an ICU bed for an extended period of time if that's not what they want. So high quality, low cost. And guess what? If we start meeting patients and families where they are, if we start talking to them, including them in the decision process, they're happier about it. Their stress level goes down as we talk about the what ifs and what may happen. So all of a sudden the patient experience goes up. And at the same time, if we help our providers do this more on a regular basis and become more comfortable with this, they're more pleased. So even though they might be giving this really bad news to patients and families, their response is, wow, I didn't think I could have a good discussion like this. It was really heavy duty, but boy, I did it. The result is going to be bad. Someone's going to die, but I feel better about addressing that elephant in the room. This is what we call the quadruple aim. It used to be the triple aim. Now it's the quadruple aim. That resonates with leaders. That resonates with the C-suite folks. So another question, a little bit more personal question. Have any of you all had experiences with loved ones or friends where the end-of-life care didn't go as well, wasn't as ideal as possible? So think about that a little bit. Have you had a case like this? As I reflect back, all of 25 years ago, I think about a couple very similar to the one in the corner. I was doing my training earlier on, and I was in a large clinic and a large hospital, but in a smaller rural area. And I saw this couple sitting on chairs in a hallway, and this poor man had the look just like the man here in the picture. He looked distraught. He looked scared. They looked kind of confused. Like they were out of place. And growing up in central Wisconsin, I kind of figured that they very well could be farmers, by the coveralls and the boots and everything they were wearing. And to this day, I still remember that look on their faces. And as we as clinicians are running around and dealing with high stress times and code 4 calls over the loudspeakers and things like this is not what our patients and their families are used to seeing or being around. And we need to remember that. We need to remember that this is really stressful for folks. I didn't know what they were waiting for. I don't know if they were waiting for news or a test or whatever, but clearly that stress was on their faces. So think about that as we talk about not only the business case and doing the right thing, but how have we experienced bad end of life care with families and friends? But part of what we need to do is change that culture in medicine, right? I mentioned before how we're very clinician centered. I'm the doctor, Mrs. Smith. I know everything we need to know about your heart failure and what we need to treat. So I'm going to recommend some things that we can do for you. I know which treatments, I know which medications are going to be best for you. And the discussion may not be as blatant as that, but in essence, a clinician, physician-centered approach is just that. So how do we change the culture? How do we train clinicians to become more patient and family-centered? How do we help them meet patients and family members where they are to get a better understanding of what they know about the disease process so we can better help them out? And how can we be more proactive than reactive? So often we respond to heart attacks and someone with a laceration. Oh, I know how to treat this. I know how to deal with this medical problem. How do we become more proactive? In a way, we are proactive with preventive screening, and let's get colonoscopies done and mammograms and so forth. But how do we help a heart failure patient anticipate that their breathing problems may continue over time? How do we help a cancer patient really understand that their cancer may progress over time and start making plans? So being more proactive is going to be key. But in order to really have a good end of life program, we need wonderful folks like you all that are caring for folks, or administrators caring for folks. But you really need really good top-down support. You need your administrators, you need leaders at your hospitals or your clinics or your nursing facilities to really be engaged to say, yes, this is exactly what we need to do and this is what we want to do. So you're going to hear me a couple times talk about top-down support. So this leads us to the 5 rights of end-of-life care. And I was so pleased that after 5 rights of emergency care, that premise came up. Well, why not the 5 rights of end-of-life care? So Dr. Denham was kind enough to help me through this. So what we're going to discuss over the next couple of slides is having the right conversation, establishing the right goals, then coming up with the right care plan, the right care, and then ultimately the right documentation. So let's first talk about the right conversation. What does that mean? So ultimately, you want early conversations, really upstream conversations. But I just want to call one conversation doesn't cover everything, right? So more upstream conversation really needs to be done by trained facilitators that have skills and have had training at some point about advanced directives, advanced care planning. But as folks' conditions worsen over time, then we need to look at a different type of conversation with different training. So a patient that has mild to moderate COPD or stage 1, stage 2 cancer, it's a different conversation and maybe involves different folks, which is compared to conversations at the end of life. So for those patients that have a year of life to live or less, different conversation, different folks involved. So really the main concepts is that, again, patient-centered conversations is a skill, and it's a learned skill. This is something that you have to get training for, I have to practice over time, and really should be something that we test on a regular basis. But the other key is having the right conversation at the right time in the right place, right? So what does that look like? Well, what does the right time mean? Well, ideally, you really don't want to have a heavy duty goals of care discussion with a patient when it's 2 a.m. and they're in the emergency department, right? Ideally, you start having these conversations more upstream and earlier, preferably in broad daylight with other family members around. So doing it at the right time and having the right conversation at the right time is super important. You also want to have it in the right place. Again, having your very first goals of care discussion or advanced care planning discussion in the emergency department or in the hospital with a hospitalist, probably not the most ideal place. Wouldn't it be better to have a conversation like this in the clinic with your primary care clinician, or in the clinic with your oncologist or the cardiologist or somebody like that? So ideally more upstream with the folks that you know best. We also want to make sure we have the right participants, right? If you're having a heavy duty discussion and talking about prognosis and plans, wouldn't we all want our family members to be present, or a friend or somebody like that? They can help be our eyes and ears. They can help be another support for us as we're having the conversations. So the right conversation at the right time in the right place. As far as tools for right conversation, we did provide some an advanced care planning and a goals of care documentation template. It's available on the Safety Leaders website. Please don't go there now. Go check it out later on. And as we think about tools, and as we think about conversation, it's become quite clear to me also that having a similar process for this really makes sense. So I developed a codes mnemonic. And I think this mnemonic really does apply for conversations in the clinic setting, in the hospital setting, upstream discussions, as well as downstream discussions. So the codes just stands for: C is for conversation, just encouraging folks to have a conversation, right? Which is sometimes a mind change for folks. The O is for orders. Once you have a good conversation and you have a pretty good idea what the patient wants and doesn't want, writing orders accordingly would make a lot of sense. D is for documentation. Once you have a discussion, get it on paper or get it on the electronic medical record. We want to share these discussions and the documents created with as many folks as possible, right? E is for education. Again, these conversations require skill and training and practice over time. So that education is really key, especially for the different kinds of conversation. Then S for codes is the systems change piece. It's great if you want to develop a CPR program in your hospital and you do all the training and you have all this available. If you don't have a process of how to call a code in a hospital, and if you don't have the equipment to run a code, it's not going to work really well. So the system change part is really key. Resources for the right conversation include the Improving Generalist Palliative Care for Hospitalized Seriously Ill Patients Guidebook, which is also available on the Safety Leaders website. It's just a nice guide of what we did and how it can work. So I mentioned before about a patient-centered approach, or even better, a person-centered approach. So what does this look like? So ideally, we assess all patients for unmet needs. And we know from hospital studies again and again and again, about 20% of all folks admitted to a hospital have some sort of unmet palliative need. Pain issue, nausea issue, lack of goals of care discussions. So how do we as a system, how do we as an emergency department or hospital assess all these patients for these unmet needs? Very, very key. Initially, most of these primary palliative care needs can be met by generalists. Well, who are the generalists? Well, it's you all, right? If you're taking care of the patient in the clinic, if you're a nurse, if you're a hospitalist, if you're a primary care clinician, you're all generalists. You have these conversations every single day. You treat pain and nausea and things like that every single day. And thank goodness for all of you. But most of these needs can be taken care of you all. Then ultimately, if there is crisis, if there are pain crisis or other issues like that, or there's conflict between family or a medical team, that's when specialist services may be needed, including palliative care consult. When you're looking at outcomes, right, really the guiding principles, it has to be a combined effort. I think we all know that just providing education and assuming that education is going to affect change is not always that helpful. Some studies I've seen have shown that education alone is only about 30% effective, right? So, having a lunch and learn is great. Providing education and training and teaching the folks is wonderful. Everyone loves a free lunch, right? I do. But if you don't have the systems change piece along with that, if you don't have some sort of a process and accountability and a data process, you really can't improve outcomes. So just kind of remember this piece. Education is great, but you got to have systems change to really get good outcomes. So just a little bit about what we did at Aurora West Allis Medical Center. Our burning platform at our community hospital, about 140 beds, is that we saw too many folks dying in the ICU. We saw too many folks dying without goals of care discussions, without advanced directives. So after doing a lot of data review, we found out that really we were lacking in goals of care discussions and training for goals of care discussions. So we started doing training for initially our hospitalists, but then other folks. We started with Dr. David Weissman's communication training process. Started with small, 20 people or less, just so it was a little bit more comfortable in a smaller setting. And part of our focus is we spent a lot of time, at least initially, discussing personal attitudes. What makes it difficult for a clinician, a doc, an advanced practice clinician, a nurse? What makes it difficult for them to have a conversation with a patient or a family member? It was fascinating to hear what folks had to say. Well, I have a hard time talking to them because I don't know what words to say. And if we start talking about goals of care, they might lose hope, and I don't want them to lose hope because of me. Or if I start talking about really difficult areas, I might get sued. So a lot of varied ideas and opinions from folks. So being able to talk through that and do some cognitive reframing was what's usually helpful. So if the concern was, I don't want this patient to give up hope by talking about things, well, part of what we train and teach is, well, let's redefine hope. If a patient that has stage 4 metastatic terminal cancer is saying, what I'm hoping for is to be around in 3 years to see my daughter graduate or get married or something like that. And in your mind, you're saying, wow, I think they only have 6 to 12 months to live. If their hope is for a cure, to make a comment of, well, I wish that was the case. I wish we could cure this stage 4 cancer. What else are you hoping for? What else can we do to help you out? Well, if I can't be cured, I want my pain better controlled. That's something we can help with. That's something we can do. So teaching folks what they can do and how to rephrase has been quite helpful for folks. We also spent a lot of time practicing. We did a lot of didactic works initially and information about legal and ethical issues. We spent a lot of time practicing on those micro skills. We spent a lot of time working on how to have a goals of care discussion, what words to use and not use forth. And that really was the key. Our agenda, again, really about a lot of didactic information, probably information that a lot of folks haven't had in the past. Prognostication is a huge piece of what we teach. There's no way you can have a really good goals of care discussion or discuss code status if the patient really doesn't understand what their disease process is and what it might mean in the future. So most folks think about prognostication as time. Hey, doc, how much time do I have left, right? Well, sometimes it's difficult to determine that. But we do know as clinicians what might happen with their heart failure over time, right? Someone that has class 3, class 4 heart failure, we can anticipate that their breathing problems may continue in the future. We can anticipate that their cancer may worsen over time. So it's partly our role to prepare patients and their families for some of these problems in the future, so they can anticipate some of them and so we can anticipate some of them. So prognostication is huge. Talking about hospital policies, informed consent, all that is super important. But the last half, as you see, is really the role playing. Everybody loves role playing, right? Probably not so much. But it's a great way to practice using words. In a role-playing situation, we have a doc and a patient going back and forth with each other. It's a great way to really practice words, call timeout in a safe environment, saying, I don't know where to go from here. So that was really a big part of our training overall. And it was honestly very well received by the clinicians. So initially, just from a process perspective, we trained the medical exec committee at our hospital. We got buy-in. We had them come for this initially 7-hour course. Now it's more of a 4 to 5 hour course. And we trained the chief of staff. We trained the medical director from oncology and from the hospice service and from the emergency department. And we showed them what this course is all about. What amazed me from this was a couple things. One is that once we trained the medical exec committee, all these medical leaders, when we went back and said, hey, we need more funding for future courses, they said, absolutely. How much do you need? When are you going to do the courses? And when are you going to train everybody in the hospital? Because we see how important this is. So training leaders like that was super helpful for us as we promoted this further. So we went from training hospitalists and staff in one hospital to over 400 hospitalists, EM docs, specialists, case managers across the entire system, over 16 hospitals. What also surprised me was initially we were focusing on hospitalists just because they take care of the most sick patients and do most of the admissions. But we found out very quickly, the emergency medicine clinicians came and said, hey, we're having these discussions all the time. We just don't have a lot of time to have them. Can you teach us some of those skills and some of those words to use so we can do them in the emergency department? We also heard the surgeons saying something similar. Hey, we're having these really tough discussions with patients and families about surgery and not doing surgery. Could you help us? Because we do a lot of surgery we don't think is indicated, but we kind of have to because that's what the patients want. So I was very, very pleased to see folks like that say, hey, we want some of this training. We want extra help. Without fail, every time we would do one of these courses, I'd have one of the clinicians, seasoned clinicians, raise their hand and say, yeah, this is great. Boy, I wish I would have had this much earlier. Why aren't we doing this training with medical students and learners? And the great news is we are. Thanks to some great collaboration and partnership with a medical student through the University of Wisconsin, we developed a palliative medicine curriculum, which includes exactly this. A way of giving bad news. How do we have goals of care discussions? How do we have code status discussions? And it was hugely, hugely successful. And I'll share some of those results in a minute. But this then expanded to sharing the same information, the same training for family medicine residents and internal medicine residents. Then we started thinking about outside of the hospital. Who else would need this training? What other clinicians are interested in this training? And this quickly evolved to training APCs and other providers within the nursing home. They very much appreciated this approach. They very much appreciated the idea of having goals of care discussions with their patients. And it really did help with continuity of care. Just briefly, physician follow-up. Mentoring. We wouldn't want to train somebody on how to do colposcopy and not have any follow-up training with them. Same thing applies to communication training. So we provided a couple mentoring sessions with these clinicians afterwards, partly to make sure the skills were going okay, they were comfortable with the discussions and to give some mentoring. We also helped with the documentation aspect. This is just a basic sample of a goals of care template. Part of the questions that we ask are, does the patient have an advanced directive? Is the patient decisional? Do they have the capacity to make decisions? And what is the patient's code status and rationale behind code status? And ultimately, what are the goals of care? Since we developed this template, we've developed a more complicated and more in-depth template as well. So I mentioned briefly about training clinicians, and this was a paper that we're hoping to have published soon, really looking at how do we evaluate this training program and does it really work? So we did the same program. We did online learning, we did in-person learning, and some post learning, and we looked at the assessment from the clinicians, and we started with 77 clinicians, primarily emergency medicine docs, to see how comfortable they were with the training. And our results were fantastic. We looked at baseline comfort level for folks. We looked at their comfort level almost immediately after the training, and then a year post-training to see if it made a difference. And what's amazing, when you kind of go left to right, you can see their initial comfort levels with delivering bad news, and discussing CPR and DNR status, discussing hospice, artificial nutrition, and prognosis. Going from baseline to follow-up, their comfort level all increased across the board. And even a year later, even though there's a little bit of a drop-off, they still did better and felt more comfortable compared to the baseline. So this communication type training really does help and helps folks feel, specifically clinicians, feel more comfortable. Well, what about those medical students? So again, I mentioned Natanya Russick, a fantastic med student who worked on this project to help medical students have these type of conversations. So what she studied was looking at comfort level and confidence from the students before the curriculum and then post the curriculum. So the numbers are a little confusing here, but low numbers are good and higher numbers are not so good. And what we found out is that after the training, after the curriculum that she helped develop, student confidence increased for breaking bad news and discussing goals of care discussions. The comfort level also went up for breaking bad news and caring for patients with strong emotions. So even for learners, even for student doctors, their comfort and confidence level improved with this training. This was really fantastic news from our perspective. So you have the right conversation. You have the right conversation at the right time at the right place, right? Then what's next? Well, the next piece is establishing the right goals. The important piece of this is whose goals? And the answer is patient goals, patient and family goals specifically. We want to make sure that really the goals are synchronized with the patient's personal values and desires. And then ultimately, we want to match up treatment plans with those patient and family goals. Does that sound a little bit different? Is that what we do now? Hopefully so, but I don't see it a whole lot, unfortunately. So part of the concepts for right goals is really again, determining the patient's goals, meeting the patient and the family where they are. How do you determine the patient's goals? Well, you got to ask them. You got to meet them where they are. You got to try to walk in their shoes a little bit to really determine what matters to them most. You have to have that prognosis discussion. Does this patient and family really understand their disease process, their diagnosis? And then from there, develop a plan for future deterioration. What do we do if the heart failure does get worse? Let's work on that together with the patient and family. But here, another key concept is really not only looking at the patient's body. Are they having pain? Are they having nausea, right? We also want to assess the mind. How are they doing with coping and closure with this? Are they having anxiety? Are they having depression? How are they dealing with this new diagnosis? Whether it be cancer, whether it be heart failure, maybe it's even diabetes or dementia, right? But then also doing that spiritual evaluation. So important. Is spirituality, is religion important to the patient or not? It may not be. So in palliative care, at least, we have what's called a peace tool. For every consult we do, whether it be inpatient or outpatient, we try to look at all these different domains on a regular basis. That's really our way of being as patient and family centered as possible. So the peace tool, the P is for a physical assessment, pain, nausea, constipation, those type of things. E is for the emotional assessment. Are they having problems with anxiety? Have they had depression? Is that part of the reason why they're not recovering so well? A is for autonomy and advanced directives. And does the patient really understand their disease process and what's going on? Or is there some confusion? Do we need to help connect the dots a little bit? Have they filled out advanced directives? Have they picked the power of attorney? C is for coping and closure. How are they dealing with this diagnosis? And closure more for end of life. And then E is expenses. I kind of joke around with patients. Generally, I don't care about expenses unless they've put me in the will or something like that, which would be cool. But if you're discharging a patient to a facility, and there's going to be room and board charges, if the patient doesn't have money, that's not going to work really well, right? So really kind of assessing where they are that way is super important. And the T from tool is transcendent or spiritual assessment. How can we meet them where they are? Is faith important to them? Is spirituality important to them? What gives them comfort when they are dealing with a bad disease or a bad disease process like the one we're discussing now? So the FICO tool that's included, and a link to the FICO tool on the PC Now website, it's just a nice down and dirty basic assessment tool. And we should be asking all our patients about this because it can be super important for some folks. For other folks, not so much. But we're not going to know unless we ask. So really important. So I would argue that even though palliative medicine uses the PEACE tool as part of our domains and part of something that we do every single time we see a patient, I would argue whether or not primary care should be using a similar tool, right? Or the hospice team or the emergency medicine team, right? So other resources to share, we shared a link for a fast fact determining prognosis in advanced cancer. It's a great kind of example of how to look at and discuss prognosis. And we also will provide some information on SBAR. A lot of us know about SBAR, situation, background, assessment, and recommendation. What I think is really cool is SBAR for patients. So again, Dr. Denham can talk more to details in the story of this later on. But again, we think of SBAR as a way for nurses to report concerns and problems and so forth with one of their patients, with the attending or with the hospitalist or whoever. But I thought this was fascinating. What about SBAR for patients? So as opposed to a way of addressing patient issues and a clinician making a decision, what if we use SBAR for patients? What if we did this tool for them? S would be the situation. What brings this patient or family into the clinic or into the hospital? What are some of their active medical problems? What's concerning them most? And why do they come in? What concerns them most? Be your background is what led to these situations. What's been going on the last couple of weeks, the last couple of months that led you to this clinic visit, hospital visit, ED visit? A little more discussion about prior diagnosis, but really what's important information from the patient's perspective. What do they think is important? Why are they here? And what are their biggest concerns? Or the assessment is really a brief summary of where they are and kind of what leads them to this request for help. Boy, I need some pain medication, or boy, I can't handle this nausea anymore. Can you please help me with this nausea, right? And then the R is the request. Remember, this was recommendation. This is a clinician recommending something. In the SBAR for patients, the R is a request. What is the patient and family requesting? So the patient might be saying, yeah, I've been having nausea for weeks. I can't stand things. I keep wanting to throw up. I can't keep anything down. I need some answers why I have nausea and some treatment for that nausea. What do we do as clinicians? Well, they're here for nausea, but boy, I'm really worried about blood pressure. Let's focus on blood pressure, and that's what I'm going to spend most of my time. In this case, really the patients and families get a chance to really ask what they need and what they want based on their interpretation of what's important. Again, this is human-centered. Health literacy is huge. We want to be using language that obviously patients and families can understand, and then really doing that active listening. Again, even though I consider myself supposedly a communication expert, my wife might say I need a little bit more help with the active listening piece, but that's for a different discussion. So I would like to share a really humbling experience with a patient I will call John. John was in the ICU for an extended period of time. Was on a ventilator, had a lot of medical problems. And we planned on having a family meeting, which was fantastic. Family members were able to come into the room. We had a couple of children, wife. We had this great goals of care discussion. I talked about what was important for John. We knew that he was a pastor, so we knew that his faith was strong. But we found out very quickly, myself as a palliative medicine doc and the hospitalist, that the faith family was very strong as well. So they had great questions about, how's the patient doing, and do you think my dad's going to get better, and what's the chance for his recovery overall? But at the end, they started asking other questions. Well, you do the best job you can, but we know Dad has a very strong faith, and he knows that he's going to go to the Lord. Then they asked, would it be okay if we said a prayer? And we said, of course you can say a prayer. And to the hospitalist's credit, he stayed in the room while the family did a prayer. And it was just the most beautiful prayer. It was so humbling, for them to include us in their family prayer for their loved one. It's just amazing. So after the prayer and after the family left and we discussed goals and such, I went back to the room to check on the patient. And I was looking at the IV pole. And it struck me, here's this big IV pole with all these things hanging all over the place, right? And I started looking at that. I said, what's the most important part of this IV pole for this patient? So the infectious disease doctor might come and say, wow, clearly the antibiotics are most important for this patient, because without the antibiotics, we couldn't treat the pneumonia. The cardiologist would probably come in and say, well, those vasopressors, those medications that are keeping the blood pressure up, those are crucial, because without good blood flow and without keeping the blood pressure up, he would die for sure. The kidney doctor might come in and say, nah, clearly it's the IV fluids, because if we weren't giving fluids, his kidneys would shut down and he wouldn't do well. But I wonder if we ask the patient, or even the family in this case, what they would say. What is the most important part for this patient on this IV pole? Could it be those medications? Probably. Very, very, very important part for him. What about that sign? They left a scripture at the bottom of the IV pole. Not only did they leave the scripture verse, but also pictures of the family. And knowing that the patient was a chaplain, knowing that faith was so important to him and the family, could this focus on God? Could this focus on faith be the most important piece? And how do we as clinicians meet patients and families to recognize that, to see that value, to see what's really important for our patients and families? Very humbling experience. So you have this great conversation in the right time, right place, right folks involved. You do patient-centered goals, and you make sure the patient understands what's going on, the family understands what's going on. Then you move to the right care plan. So this is where we really want to make sure, once we've established those goals, we start writing orders that make sense for this patient. Full code status, no code status. Boy, the patient wants more information about whether or not this is cancer or not. Well, we better have an oncologist come see them. So this is where the care plan comes. We start getting some of that extra information. This is also the time when you start doing things like documenting the discussions and looking for advanced directives. And if they're not done, after we have this great goals of care discussion, ask the patient, who should make decisions for you if you can't make decisions for yourself. Let's get these documents done just in preparation so we have this right care plan in place. This is also the time, once you meet the patient where they are and you understand what they understand about their disease process, let's plan for the future a little bit. Let's plan for future deterioration. What happens if your heart failure gets worse? What happens if your breathing gets worse over time? Does coming back to the hospital make sense? If your swallowing gets worse, would tube feeding be something you'd want to consider? So having these discussions more upstream, early and often, really helps prepare the patient for questions that might come up, but also their family members, so they have a better idea what's going on. Tools, the National Hospice and Palliative Care Organization has a great website. And we've provided a link with NHPCO's advanced directives section. Where you basically, regardless of the state you're in, you can go to that link and find out what kind of advanced directives are in your state. So it's a wonderful, wonderful resource. Other resources, Honoring Choices Wisconsin also has a fantastic website with videos, with basic advanced care planning information for clinicians, but also for patients and family. Honoring Choices Wisconsin is just amazing. They took the Respecting Choices model out of La Crosse and implement it throughout the entire state. So very, very proud of what they've done. And we also are including a resource from Fast Facts on myths of advanced directives. So please check those out as well. So you've had the right conversation at the right time, established patient and family-centered goals, developed the right care plan, got documentation done, got your orders done. Well, the next part is the right care. And this is where we make sure that the care provided for the patient is consistent with the right goals and care plan. I'll say that one more time, super important. This is the ultimate measurement. We want to make sure that the patient's care that's being provided is concordant, is consistent with that patient's goals and plans. This means if a patient says, boy, I don't want to be resuscitated, I don't want to do those type of things, well, we need to make don't get resuscitated. But on the flip side, if a patient says, hey, if my heart stops, I stop breathing, or my blood pressure drops, heck yeah, I want you to do everything. Well, we darn well better get them to the ICU. We better transfer them or provide all the aggressive care that is needed. But part of the concept of right care is measurement. How do we know that we're doing all the right things? How can we assess that our processes are working? So measurement of clinical and operational outcomes, super important. This is where the expenses, this is where the finances come in. This is where you can prove that doing good quality care can save you money. And this is where some of those numbers can be important. This is also where, after you've done that mind, body, spirit assessment initially, this is where you provide that care. So if they're having problems with anxiety, or if they're having problems with depression, let's make sure we provide the right care and the right treatment for these folks. If a patient says, boy, I'm scared to die because I'm afraid I'm going to go to hell, well, that's above my pay scale, right? I better get a hospital chaplain in to see this patient as soon as possible, or find out if they have their own spiritual leader that can come in and help out with that. Very, very important. But along the way, we have to make sure we communicate. Constant communication, again, not only with the patient, but with the family, with that family unit. You know, hey, Mr. Smith and family, I know our plan was to discharge you in the next day or so, but because of some worsening heart problems, I think we need to stay in the hospital a little bit longer. Does that make sense? Okay. Tools. Hopefully you've all seen Dr. Jean Huddleston's presentations. Her mortality review process, her safety learning system is fantastic. What a wonderful way to evaluate charts, to look at charts, to look at patient care, to make sure we're providing the safest care and the highest quality care for our patients. And the data that's produced from her work is just amazing. So we have a link to that as well. So just a little bit of data. I shared this once before, but just to reinforce what we discussed. When we provided changes at Aurora West Dallas Medical Center, when we provided communication training for clinicians, when we provided the structure and the systems change, when you utilized Dr. Huddleston's mortality review process, looking for opportunities for improvement, we found out that really good early effective goals of care discussions can improve patient-centered care and help with mortality. So this is data from several years ago, but with all these changes, outcomes we saw were decrease in patient deaths, decreased ICU deaths. For folks that did die in the hospital, their median length of stay went from 6 days to 3 days. So what's that cost avoidance, right? We saw that our nursing home to hospital readmissions dropped. Our code 4 calls in the hospital decreased by 50%. But at the same time, our rapid response team calls when patients start declining doubled. So we weren't coding no-code patients. We weren't having as many code 4 calls, but we were rescuing patients sooner. We also saw the 30 days admissions and those terminal readmissions went down. But at the same time, we saw our hospice referrals go up. We saw our advanced directive number go up and comfort orders go up. More specifically, 30-day readmissions dropped by 7%. Our hospital death rate dropped by 27%. At the same time, our discharges went up. Hospice referrals went, advanced directive completion went from 50% to 77%. Restraints went down, and also our palliative medicine consults came down. So as a palliative medicine doc, I'd say, boy, that's bad for business. For patient care, that's a good thing. I'm okay with that. Sorry for the graph and all the numbers, but this just kind of gives you an idea of our mortality rate. Back in 2014, when we started this whole process, we were averaging about 140 deaths per year. A year after implementing all these changes, our deaths in the hospital dropped down to 97. So that's the 27%. And those numbers continue to drop over time, over the next couple of years. My understanding is that in 2019, our deaths were down to 58. So what a huge change. Our observed to expected mortality also dropped. So this is important to folks because, you know, the folks that are really sick that come into the hospital, some of them you just expect to die because they're so sick when they come in. You don't expect a healthy 50-year-old to die, right? So what we saw is that our observed to expected mortality rate also dropped, which means we were diagnosing folks that had more severe illness and documenting better, saying, yeah, they were sick. They didn't have just UTI, they actually had sepsis, right? We rescued folks sooner, and those numbers continue to go down as well. So is this scalable? Could we do this at a hospital other than Aurora West Dallas Medical Center? And the answer is yes. We applied the same model to a smaller hospital in South Milwaukee. They have probably 60 to 70 beds or so. We provided communication training for the hospitalists, the docs. We showed them how to document goals of care discussions, implemented a full mortality review process, just like Dr. Huddleston's. They also dropped their observed to expected number, and their overall rate of mortality dropped 37%. Lastly, from a mortality review process, again, using Dr. Huddleston's safety learning system, we were able to expand our mortality review process, not just from 1 or 2 hospitals, but all 16 of our hospitals throughout the system. What is really interesting, though, is that across all those hospitals, those opportunities for improvement were pretty similar for each hospital. So a little bit of variation here and there, but surprise, surprise, our hospital's #1 opportunities for improvement were end-of-life opportunities. Goals of care discussions weren't done. A palliative medicine consult could have been done and wasn't done. We saw concerns with documentation in general. treatment care opportunities, deteriorating patients that weren't recognized. This is how, with mortality review, but also using the safety learning system, gathering data that's specific for your hospital, your institution, can be super helpful. So in general, how does all this stuff really make care safer? Well, again, you've heard me talk about it before. Providing the right care at the right time at the right place is crucial. Having these conversations upstream and often is really, really important for patients, and to really identify what matters to that patient, what goals matter to this patient, and providing the care that's concordant with that. This way, we prevent resuscitating no-code patients, and we also rescue patients sooner, right? If we clarify their goals, all of a sudden we're not providing unwanted procedures or tests or surgeries. We're not doing things to people that they don't want. And ultimately, the goal is really providing that care that's concordant with their wishes. Lastly is the right documentation. Once you've done all this work, you really want to make sure that the plan and the right care and all these discussions are not only documented, but really are used throughout the system. You want processes and systems in place to make sure that all this documentation, all these plans really flow along with the patient. So regardless of what setting the patient is in, the community setting, outpatient clinic setting, emergency department, hospital, nursing home, or hospice, everyone knows what the plans are. Everyone knows what the patient's goals are. And all of a sudden that continuum of care is seamless. We help them across the continuum. So good care coordination is hugely important, documentation of those goals of care discussions, and then really the tools are more of a standardized template for organizations, checklists, flow charts, and so forth. And I'm really excited to see next month, the 5 rights of medical records. So just briefly, in just the last couple of minutes, systems change. I've talked about that several times. Well, ultimately, from a quality improvement perspective, all patients should have some sort of a goals of care discussion. Even a newly diagnosed patient with diabetes needs some sort of basic conversation. We want to make sure that these goals of care templates and these discussions are embedded in the electronic record so they're easily accessible by everybody. And then we really want the quality department to do these chart reviews. This is where you get accountability. So for them to be looking for goals of care discussions, advanced directive completion, especially for sicker patients, is really important. Ideally, if your computerized system can do that for you, that's even better. And weekly mortality reviews or weekly reviews for folks that have 30-day readmissions, or review for patients that have had an unexpected transfer from the floor to the ICU, or transfers from the nursing home to the hospital. Doing reviews of those goals of care discussions in that process, it can be really important. Then always planning care coordination. How do we work with the nursing homes? How do we work with the emergency department? How do we make sure that, if a patient needs a DNR bracelet, they have such a thing? Future goals, again, screening all patients for unmet needs. That's on us to be proactive. Follow-up training for hospitalists, other clinicians and nurses is super important. We all have to not only do CPR, but CPR retraining. Wouldn't it be a really great idea to do communication training for them as well? Ultimately, having a train the trainer process would be good to embed this really well. Apply system changes to all settings. Again, having this in all those different settings, home, community, nursing home, hospital, clinic, is imperative. And wouldn't it be great if we had our medical executive committees in the hospital, or our board for the outpatient setting or the nursing home? What if we had goals of care conversations as one of the quality metrics? If they saw so much value in this work and the discussion and the outcomes, having it as a quality metric would be hugely, hugely important. So if you're sitting out there saying, we're absolutely going to do this, we've got to get going, how the heck do we start? Well, find your partners. Talk to senior leadership at your hospital or your clinic. Talk to the president of the hospital. Talk to the CMO or CNO or the director of quality. Talk to the risk folks. You hate thinking about the risk aspect of this, but the risk is an issue and is a concern. Talk to them. Talk to the safety folks. Talk to your medical exec committee. Remember, top-down support is hugely important. You can work as hard as you can at the ground level, and that's really important too. But you really need support from leadership, not only financially, but just to reinforce all this. Have leadership take the training, develop your own mortality review process, hopefully using Dr. Huddleston's process. Really work on strategic planning. What do we want this to look like in a year, in 3 years, in 5 years? What data do we need to gather? How do we make sure that there's accountability? And then culture change is huge. I really didn't appreciate this part until Susie Fielding, Director of Quality at West Dallas, taught me that culture change is a process, and it's a process that can take 3 to 5 years. So being patient, but being consistent is super important. Measurement-wise, advanced directive completions, advanced care planning processes being done. Are we doing goals of care discussions for our appropriate patients? And then ultimately, I mentioned concordant care. Are we providing care that's concordant with the patient's wishes? And then following along the way, safety events associated with patients' goals. So ideally, the dream scenario is, are we really providing patient or person-centered care? Are we providing family-centered care? And is that really the norm? Is that really our focus? Is that really what we're trying to do as a system, as a hospital, as a clinic, as a department? We'd also hope that goals of care are completed and then documented for all appropriate patients in all settings. That should be an ongoing story. That should be an ongoing discussion. It's not a one and done. We also want to make sure that goals of care conversations are really part of credentialing at some point. Well, if you're going to be in this hospital, I just started with Theta Care. I have to get my CPR done. I have to make sure that's done in order to be credentialed. Well, maybe goals of care training should be part of credentialing as well. And then ultimately, is the patient care that we provided really consistent with their wishes? So just in conclusion, if you all can think about this as culture change, communication training, skills, and so forth, what we're really looking at the end of life and the 5 rights of end of life care is we want to improve quality of care that we're providing for our patients. We want to provide safer care for our patients. And by doing that, we can reduce cost. By doing that, we can make patients happier with what's going on. And by doing that, we can make providers happier with the work that they're doing. So thank you very much for your time and for being here.
Wonderful job, Tim. We really, really appreciate such a terrific presentation, and you synchronized it beautifully with the 5 rights framework. We'll first go to Heather Foster to react, and then to Dan Ford again, followed by Arlene Salamandra, and Jennifer Dingman. Will have Dan close us. So Heather Foster is an RN. She's been a infection preventionist. She works in Colorado. She's been both ICU, frontline care, and a wonderful contributor to our programs over time. She also was a winner of the Pete Conrad Global Patient Safety Award with the other folks that are on the panel. Heather, would you like to just react? You deal with this on a daily basis in a smaller hospital and community. Would you like to react first? And then we'll go to Dan Ford.
Can you hear me, Chuck?
Yes, we can. Great to hear your voice.
Yeah, same here. Yes, thank you so much, Dr. Jessick, for all your work that you're doing in this area of patient care. We do, as many nurses and providers experience, the need to have this conversation at all levels of the patient experience. But I'm going to just mention a story. Years back, I had a patient who was ailing from heart failure. And as a nurse, we're taught to advocate for our patients. And I've been doing a lot of soul searching in this area, as this is a passion of mine. But where is the nurse and their role in advocating for maybe palliative care versus aggressive treatment? And where is our voice in that? We're at the patient's bedside more than the physicians are. Our relationship with our patients become more personal than technical. And I feel like we're sometimes a lost voice in this discussion. And patients are going to go with the recommendation of most doctors. So this is great that we're finally having this discussion, and that providers have now a means and a ways to learn the skill. However, this patient that I want to mention, he's heavy on my heart right now. He was definitely struggling. And so on discharge, I had mentioned a possible hospice consult for the patient. And to this day, I remember, and this is not to put the physician down, But he said, well, Heather, just because he's 98, he doesn't need necessarily to be on hospice. But that's not what I was trying to get at. I was trying to communicate, and did ultimately, that the patient was suffering. But anyway, he went home, and over the weekend, I found out a week later that he had committed suicide at home, as he had started worsening. And I think that has just, for me, will forever be my drive to advocate for patients who no longer want to, and some of them are afraid to say, I don't want that doctor, or I don't want that provider, that treatment. So I think making it a safe place for those patients to be able to express what they truly desire. So thank you so much for providing this this webinar today. I think it's crucial to our healthcare in the U.S. And just great to be a part of this today.
Thank you, Heather. Tim, would you like to react to her story real quick before we go to Jennifer?
Yeah, what a tragic story. And it makes you think, what could we have done differently? What kind of support can we provide for patients? And nurses are crucial with this. Thanks for bringing that up, Heather. I think nurses are ultimately even better at this than clinicians, just having these conversations. But how could we have reached that patient where they are? How could we have figured out what matters to them? Coping and closure, but what gives them strength, and do they not have strength because they have nobody around? So boy, what a tragic story, but what a great learning experience that we got to meet folks where they are, and nurses are key part of that.
Great. Thank you, Tim. Jennifer, would you like to react? We're not hearing Jennifer. Arlene, do you want to unmute? And we'll go to Arlene. We'll come back to Jennifer.
Okay, thank you. Thank you, Tim, for the great presentation. I like the point of knowing how to communicate with your families. I think a lot of times, my personal experiences, sometimes we feel like they're not being heard, the patient's not being heard. And so that's so important for care, is knowing how to correctly communicate with your patient and the family. And then making sure not only, the decision of what they want to do with their care, that they're fully informed of their options. Don't hold anything back, and but tactfully tell them what their options are so they can make an informed decision. So that's real important too. And this is what patient-centered care is, and involving the patient in their own care, making sure they understand everything, communicating on a level that they understand. So I just want to thank you, Tim. It was a very good presentation. Thank you.
And Arlene, I moved quickly. I was watching the time, but Arlene also, as part of our Saturday morning team, was the winner of the Pete Conrad Global Safety Award, has worked in nursing homes and been a wonderful champion for preventing bullying. And Arlene, thank you for your steadfast support there. Jennifer Dingman, we're going to ask Jennifer to speak next. She's actually the voice of our patient in our coronavirus community of practice, and also a steadfast supporter of patient safety, as has been Dan and Arlene, and also served on many committees and programs, and a co-author with them. Jennifer, would you like to comment?
Thanks, Dr. Denham. Dr. Jessick, thank you so much for your presentation. It taught me so much. And Heather, I have to reach out to you and give you a virtual hug for what you went through with that patient. I wish more people and clinicians were feeling the way that you do about this and not afraid to come forward the way that you did. So thank you for your courage and your caring heart. This issue is really hard for most people. We have a culture where we believe that medicine is an all cure-all and we're not going to die. We don't believe that deep inside. And we really need to change the culture of our people to understand and accept that death is part of life. I myself have gone through several experiences losing loved ones, and I was totally unprepared in each case. One of them was terminally ill, the other two were not. And, it was just really, really hard. And it was also very difficult when you have clinicians that are, I had, my mother was in a coma for 7 weeks and she never recovered. But it was very confusing to me. Some of the clinicians were telling me that, there was chance of recovery, others were not. There were things that happened that shouldn't have. We'll never know exactly what happened. But I think we need more consumer education about this subject because it's very, very important. And people need to know before they fall into a situation what they're going to want. And then, of course, people can change their mind too. Christopher Reeve is a perfect example of that. So I think our country is really lacking, and we really need better leadership in medicine. And what you're doing here is just so amazing and so wonderful. And I have to thank you. And I encourage everybody listening to get the recording out to your colleagues, friends, family members, and spread this very, very important work. Thanks again, and I'll hand it back to you, Dr. Denham.
Thank you, Jennifer, and thank you for all your support. Tim, let's go to Dan and get his reaction. And then, Tim, I'd love for you to share the story of the evolving patient and family that we've discussed together over the last couple of days, where, Tim, we called you in to help us actually with a loved one. But we'll go to Dan, and Dan has been introduced, and he's a terrific contributor, as I mentioned earlier. Dan, your reactions. Is Dan still on where Dan is muted? Can't hear you, Dan. Can you mute your phone?
It's 6 to unmute.
We're not hearing Dan. Maybe Kyle, you can text him, and Tim will go to the story and come back to Dan because we have ample time for Dan to comment. Tim, would you like to kind of tell a little bit of the story of the loved one that I shared with you and the challenges we faced, and then we'll come back to Dan.
Yeah, thank you.
And I'm here when you're ready.
Okay.
So just really briefly, Dr. Denham introduced me to a friend of his who's unfortunately very kind of typical story. Her dad's not doing well, is in a facility all by himself, is having swallowing problems, has a history of cancer. And she's actually a chaplain, so she has some background information. And my heart just went out to her, number one, because her poor dad's in a nursing facility not doing well and she can't see him. But then number two is that when she was able to go in, thank goodness she was able to go and talk to him and talk to the doctor, the best job possible. By no means would I be critical of docs who I think have good intent, but she was so confused by what we could do and should do. And boy, we could start with home care and then maybe some palliative, and then we could add hospice, and she didn't know what that meant.
Right.
Again, this is not a criticism of the clinician, but they didn't know how to communicate or how to discuss goals. And so my recommendation to her was let's just clarify goals. Talk to dad first. How aggressive a care does he want? How is he with this whole process? Is he looking at more of a comfort care approach or full steam ahead? And get an idea from him what he wants and doesn't want. And then from there, we can figure out if that makes most sense with a hospice approach or a palliative approach or usual medical care. And honestly, just a simple suggestion like that and reframing how she discussed that with not only her dad, but also the team seemed to really help her. She was relieved and felt like she had a way of moving forward. So it wasn't much. It wasn't rocket science. It was just a reframing and rethinking how we had that discussion. And I think that helped. So I would not say that's a Tim thing. It's not because Tim's all brilliant and a fellow and all those things. Because I'm not brilliant. I'd like to think I am. I'm not. But it's just a little different focus, a little different approach, and trying to meet her where she was and her dad where he was. And that, I think that made a difference for her and for them.
Thank you, Tim. And now I might add to that after Dan. Dan, you ready to go? Go ahead, please, Dan.
If you can hear me, I'm ready.
Yes, sir.
Yeah, Tim, two comments and a question. Your idea that the great end of life care can drive patient safety is brilliant, and we really need this. I've been involved in patient safety for 18 years now, dating back to a family tragedy, and we're still working on it. But if I'm understanding what you're saying, if we get this right at the end of life, we can back up and apply these principles all the way along in the whole interaction in various healthcare settings. Secondly, your slide that is labeled "How does this make care safer?" is a dynamite slide. I mean, to me, that just captures it all. That's part of the dynamite process, by the way. A question, and I actually kind of prompted you this over the last couple of days, but can you would the doctors be willing to have the voice of the patient into your palliative care training and planning, and be another quote unquote find your partner in that slide that was one of your last slides? Maybe the negative side of this is, or do we leave it to the doctors to speak for the patient? Just for information, I live in Grand Rapids, Michigan, Spectrum Health. I've been very active volunteer there on some committees and councils. For 4 years, through 2018, I was a member of Patient Family Advisory Council. I participated, as the other PFAC members, in a number of process improvement events. These were Lean Six Sigma approach in adolescents, which is affiliated with Medicare, as you know. It was a key resource to Spectrum Health in those. Every process improvement event had a voice of the patient. I'm not saying you should necessarily use process improvement events, although they are very helpful, but to invite the voice of the patient into your planning so that they can give you that perspective with all that you've been talking about today. Just an idea.
Yeah.
Thank you, Dan, and I couldn't agree more. And I would agree with having that patient voice, and actually the patient voice is critical with this, and I would strongly recommend that. You know, we can pretend what do we think the patient's saying, what do we think matters to them, but actually have patients there when you're doing process improvement to really hear from them. Again, I'm not critical. I don't want to be critical of docs or clinicians, but they assume patients want us to keep doing stuff no matter what. And in some cases we don't. So to hear it from a patient's perspective as we're developing policies and process and looking at data, I think that'd be a huge eye opener for them to look at things from a different lens. I think that'd be fantastic.
Great. Thank you, Tim. We're so grateful. We will finish on time for everybody. We went a little bit longer last time, and we know many of you have clinical duties and that kind of thing. So we just want to remind you, with your families within the COVID environment, we're in a very, very difficult time right now with another surge coming. We've got spring break. We've got many grandparents want to see the kids over spring break or ski week or whatever it's called in your local area. And so we just want to remind everyone that if you do bring your family bubbles together, how critically important it is, especially with the new variants that may be more transmissible, to be very, very careful about sharing the same airspace, because this is an absolutely vital issue, and one that we really want to remind everyone to do. And if you go to our website, you'll be able to see that information and download the tools. So Tim, thank you so much. We want to come back to Dan to now articulate the voice of the patient. Thank you, Dan, for your questions and commentary. But now, as the speaker of the voice of the patient, would you please close us? And I want to thank our other panelists for their great comments, and Tim for a great presentation and tackling this a second time. You did a terrific job. And God bless you all. And we will hopefully see you in March 4th for our next program for our coronavirus program. But this will end our program and after Dan speaks and speaks on behalf of patients and families.
Thank you, Chuck, and I apologize, and thank you for your help, Kyle, with my technical difficulties. Maybe this comes with being 78 years old, but if I do this enough, I'll get it right. I want to thank everybody for joining us today, and I pray that you have good takeaways, and I pray for you in general with all that's going on. I want to leave with a positive quote, and that is, today you could be standing next to someone who is trying their best not to fall apart. Whatever you do today, do it with kindness in your heart. God bless everybody.
Thank you all, and we'll see you next month. And again, thank you for all of your attention and the wonderful positive comments in the chats. That ends our webinar for today.